Welcome, everybody. Good morning, good afternoon. I'm happy to open a Chief Satellite session today in advance of USAID's Local Implementing Partners meeting. The title of today's session is Institutionalizing Service Delivery, Capacity Among Community-Based Cadres. At this point, I'd like to ask you to take a moment to write your name and organization in the chat box. This satellite session is a peer learning session, and it's really important that we hear from you. So I'm so pleased that you chose to join us today. Our session is going to focus on community volunteers and the important job that they perform in OVC and DREAMS programming. Community volunteers play a very large role in the global HIV response. Indeed, in the new draft of PEPFAR's 5-year strategy, they will be instrumental in reaching PEPFAR's 5 program goals. Namely, reaching 95-95-95 for all ages, genders, and population groups, reducing new infections, closing equity gaps for priority populations, including AGYW and children, transforming the program towards sustaining impact and having local partners lead and manage the program, strengthening public health prevention, data, and response capabilities for HIV and other health threats. Additionally, in hearing the new Global AIDS Coordinator speak at AIDS 2022, it was clear that he's dedicated to community health services. He emphasized that health services are provided locally and that the local systems need to have the capacity to provide quality services. It was also exciting to hear that he was going to start a youth movement. I'm sure that our OVC and DREAMS programs will be key in catalyzing his vision. Today, in our satellite session, we're utilizing a case study format and will share various approaches from the ACHIEVE project, which is led by PACT with consortium members JPIGO, Palladium, No Means No Worldwide, and Why Her. Then we're going to look for a rich discussion on how you are supporting community-based volunteers in your programs. So first, let me share a little bit about the ACHIEVE project. ACHIEVE's primary objective is to support community-based HIV-sensitive HIV-sensitive services for OVC and AGYW, alongside access to HIV care and treatment for children and adolescents living with HIV to contribute to epidemic control. Secondary to this objective, we focus on capacity strengthening for local partners, host country governments, and community-level actors to strengthen the foundation for OVC and DREAMS services. ACHIEVE works in 8 countries and has reached over 790,000 OVC and over 100,000 AGYW in the last fiscal year through our service delivery programs. We achieved this by working through 35 local partners, 15,243 community volunteers, and 1,383 DREAMS mentors. We also work in close partnership with host country governments through national ministries all the way down through districts to the village level to ensure that services and capacity are provided to beneficiaries and their communities. As an OVC and DREAMS implementer, a hallmark of our approach is working with and through community cadres and structures to provide services to our beneficiaries. This includes working with community-based volunteers to deliver household-level services for OVC and through AGYW mentors at safe spaces for DREAMS programs. With our focus on sustainability, our programs aim to institutionalize skills and capacity for service delivery to these community cadres. This enables us to ensure that services can be provided in a manner that reflects local contexts and needs, but also have mechanisms in place at the local level that touch households to help with the identification of OVC and AGYW for services and to link them to the support they need. With this satellite session, we want to highlight some of the different models we've used through ACHIEVE to engage the community cadre to strengthen capacity and institutionalize their service delivery roles into national structures. We will start the session with an overview of the roles of community cadres and local partners to support OVC and DREAMS service delivery. This will be led by Choice Makufa, the ACHIEVE Global DREAMS Advisor. Then Stephanie Calvez, ACHIEVE's Global CD Capacity Development and Country Programs Director and organizer of this meeting, will moderate the case study portion of this session. We will hear from 3 different Achieve Country programs on the following: coaching, mentoring, and supportive supervision for community volunteers. This will be presented by Francis Nuwagba from Rwanda. He is Achieve's OVC and DREAMS advisor. Reaching marginalized communities through volunteers. Desiree Luis, Achieve's Dominican Republic project director, will be presenting on that. Professionalizing community cadres through government structures in Tanzania will be presented by both Lavina Kakoyo, who is our project director in Tanzania, and Flora Nyagawa, who is the technical director for system strengthening. Following each of these presentations, we have set aside some time for Q&A. And at that point, we will unmute everybody and you'll be able to either raise your hand or just pipe up with your question. So the focus of this satellite session is to share what we've learned with you and what we've learned with all of you as PEPFAR local partners. But also we want to learn from you. So we'll end with a peer learning session that will be facilitated by Manji Rangshawat, the Achieve Nigeria project director. He will lead a facilitated discussion to identify other models for capacity strengthening of community cadres championed and implemented by you all. We hope that this session will not only enable us to learn from each other about different mechanisms for working with community cadres, but also to build bridges across partners so that we can work together to adapt and apply successful models from across PEPFAR programs. Now, I'm happy to hand over to Choice, who will start our discussion. Choice most recently worked with PACT in Eswatini on an OVC and DREAMS project called INSICA, or RRR. And I'm happy to say she's joined our Global Achieve team as our DREAMS advisor. She's worked on youth-focused, community-based HIV programming for over 20 years. She's joining us today from Namibia. Over to you, Choice. Thank you.
Thank you very much, Jen. That was very nice. And thank you for giving us an opportunity to share. It looks like I cannot start my video on. Stephanie, if you can work on that, I would appreciate. So we are looking at the role of community cadre in OVC and what they do also in the DREAMS program. And really what we want to discuss in my brief presentation is the institutionalizing the capacity development of these community cadre so that we continue to deliver a service that is very professional and of quality. Next slide, please. So we always want to ask, who are these community cadre? Who are these people we are talking about? They are at village level, they are known as community-based workers. People just call them community-based workers. They are usually recruited from within their own community. Most of them or some of them have actually lived the life and they are willing to plow back into the community so that other people can learn from their experiences. So they may be known as expert clients if we are talking about people living with HIV, because they are also living with HIV and they are willing to walk the journey with somebody who has newly been diagnosed. Or some of them are alumni who have just completed some program in DREAMS, or they've been working on the DREAMS program, and they are willing to help other young girls or adolescent girls for them to also know what it is like to participate in DREAMS. They are peers, like they want to help other adolescent girls, young women who are aged 19 to 35. I will come and help you as a peer and we can have a peer-to-peer talk. Or they are simply caregivers or mothers who are taking care of their own children, but they will go that extra mile to help another neighbor's child or other children with whom they interact with within that same community. Next slide, please. But when we are working with them, at most, we give them their name as it relates to the role that they play. So examples of community-based cadre is we see them in our project most of the time. We give them names or we are naming them after the actual role that they play. So these are case care workers, especially in the OVC arena, case managers, case management volunteers. If we continue on the volunteer route, we can call them community volunteers, savings groups volunteers. Some are even working in the farms or doing vegetable gardens, and we call them farmer field school volunteers. School activists, community activists, and we may even call them ambassadors, our dreams ambassadors. They do a lot of mentoring, so we may even refer to them as AGYW mentors. They facilitate sessions, they are coaches, and they are champions in some of the areas where we are wanting to do gender male streaming. So as achieved in our OVC program, in fiscal year 2022, we are so excited to know that we worked with an impressive 15,243 volunteers or community cadre who were providing these services at household level. And for our dreams, we worked with a total of 1,383 who were providing special services to our adolescent girls and young women. Next slide, please. So why are they so important? Why is it that we are celebrating them like this today? What is the importance of a community cadre? Why can't we continue providing services like at community level on our own or even at the facility? But we know that our community cadre identify with the community's cultural, language, and contextual environment. This makes them to be a very key component in our program delivery because they know the context, they live within that context, and they know the people that they are working with. They are well respected and they are seen as positive role models because they are providing a service that is required in the community. They bring in new information and they help me to access services from facilities. They are considered as welcome guests in people's homes. So you would find them making appointments. They make an appointment to see a child. They make an appointment to see a young woman, and they are welcome. And the people around the home would know that whatever they are discussing is of importance. Next slide, please. So as we are talking about this community cadre, especially in the OVC program, we want to see what are some of the responsibilities that they carry. What is their major role? I have only handpicked a few, but these are critical activities that they do that actually enhance the quality of life of the children that we serve in our programs. They do a lot of identification, especially some of those children who are most hard to reach or who may not be otherwise recognized in the community as children who require a service. And after they do an identification, they actually sit down with families to develop case care plans where they are beginning to outline what are the issues that are required, how do we monitor that you are making progress, and when everything is done, they come up with the closure of the case and then they can graduate you. For OVC or children living with HIV, they actually facilitate linkages to clinical and social services. They facilitate linkages to HIV clinical services like HIV testing for ART, and they also would follow up with you for treatment adherence, supporting you with psychosocial support. They link you with any government or any social services that are available. So they are always on their toes looking for what else can we be giving to this child. And then when they can make up a group, they would bring you together and you can facilitate group sessions using evidence-based curricula, especially around parenting, around savings groups, when we are talking about prevention of GBV and talking about gender norms. And then when we are talking about building their household stability, they are always working with the caregivers on household economic support. Next slide, please. And then when we are talking about those community cadre who are serving in the DREAMS programs, again, they are very instrumental in identifying adolescent girls, young women who are at a high risk of HIV. They help with doing the initial HIV risk assessment, coming up with criteria to say, who do we think is at risk? How do we find them? Where do we find them? And when they find them, they link all the exposed adolescent girls and young women to post-violence care, link them to SRH services, and they would do condom promotion with them. You would also find them doing a lot of screening, like wanting to find what are the services that you really require, Is it STI? Is it family planning? Is it PrEP? And then they would facilitate that you get those services. Creation and management of safe spaces where a group of 15 to 30 girls can meet and they create a safe space and they can create a stability in the lives of the girls that they reach out to. And when they are in those sessions, they don't only say, I saw you in a group session, that's it. They even go the extra mile where they'll be talking with the girls on a one-on-one. And they are also even bringing in more confidence in the girls as they are working with them. And all this work could not be done by people who are not community cadre and who are not committed. Next slide. So when they have done all the work that I described in the first few slides, it is amazing to see that we have always been relying on our community cadre for source data. When you are talking about reporting numbers, even in all our programming, you will hear them saying, if it is not reported, it was not done. If it is not recorded, it means it would not be captured. And they are becoming so vigilant in data responsibilities, such that when we are talking to them, they know where is my case care plan. Have I updated it? They are responsible for session registers. They make sure each girl who attended, I have ticked that she was here. They also come up with clinical appointment trackers where they are finding who is supposed to be going for an appointment. Am I supposed to be reminding them? And they would call them to say, remember, tomorrow you have an appointment at the health facility. When we are talking about assessment tools, they are responsible for the source data where they are assessing the vulnerability and risk assessments. They are doing graduation assessments. They do the data entry. Some of them are using paper and it is paper-based, but some are beginning to use even the electronic ones where we are giving them tablets and then they capture data at source. So in general or on average, one community cadre could be responsible for a total of 50 OVC households, or one community cadre could be responsible for as many as 120 adolescent girls and young women. And once she creates a cohort, she works with them until they graduate from the program. Next slide, please. So the issue of institutionalizing the capacity development of the community cadre becomes a very key issue that we need to think about, that we need to look at, and at different levels. So if we are looking at individual skills development, what is it that we need to do with our community cadre to ensure that they can deliver quality in confidence and they can also excel as they are providing their services? So utilization of various effective learning strategies, especially adult learning strategies, is a key thing where we are coaching and mentoring them. They work with peers, pairing of community cadre for observing, like if a new community cadre is recruited and she is now assigned to another one so that she can observe before she starts doing her own, and would also do exchange visits. Training on USAID approved curricula is a big issue for us in Achieve, where especially when we are working with curricula around positive parenting, around livelihoods and basic financial literacy, SRH, including condom education, GBV, and group-based learning. And then intentional career development pathways, especially when we are working with young women who are out of school. Promotion of CCWs to become program officers becomes one of the key things that we are celebrating, where after we've been working with a community cadre and she has excelled, she has been learning, and then an opportunity comes to be hiring officers. We do have examples, especially in Rwanda, where we have actually promoted some of our CCWs to become program officers. They do get their certification after training, and we do advocate with line ministries that they can actually be absorbed to become health workers or social workers. So the approaches to training that we are using are based on the skills training, the skills assessments to see who needs what training, and then we train trainers so that we keep on cascading the training, and then we give them certificates. and then they are now beginning to be called trainers, coaches, or facilitators. Next slide, please. So when we move away from the individual focus, if we look at local partner level, how can we as local partners institutionalize capacity development for our community cadre? So you would find that right at the beginning of our program, when we are incepting, when we are designing, or when we are implementing service delivery, capacity development is intentionally built in our program design. Local partners have actually embedded organizational policies and practices to manage community cadre so that we can manage and see that they are actually receiving the support that they need. Training and refresher training becomes mandatory and it is institutionalized so that you are sure that whoever is out there providing services has the skill to be doing it. And local partners have supportive supervision structures and tools so that we can be supporting and supervising our community cadre when they are offering their services to their beneficiaries that we are working with. Next slide, please. And then when we are looking at a bigger level, government structures, what is it that we need to be doing so that also we institutionalize the capacity development of the community cadre? Well, the first and foremost thing is for us to continue with advocacy with our national governments so that they can institutionalize capacity development for community cadre. We are happy to note that in some of our work, we actually do co-facilitation with some of our co-partners in the Ministry of Health or in the Department of Social Welfare, and we are co-facilitating curricula that they actually develop, and we take ownership of it, and they are very happy that we are using their curricula in facilitating the training. And then it also goes to say, when we are doing supportive supervision visits and we're working with our community cadre, we sometimes do co-planning with government departments for support and supervision of our community cadre. However, needless to say, we need more advocacy so that our community cadre can actually be absorbed at the end of a project. When we have demonstrated their effectiveness, we have demonstrated how they can contribute to saving lives, then they can no longer be called volunteers, but they are actually paid workers. Next slide, please. And then at the end of the day, what are some of the expected outcomes that we should see as a result of capacity development for our community cadre? Well, the first and foremost thing that we would really want to see is a quality and professional service that is delivered to our target population. No one should receive lower standard services because we are working with a professional team of people. And then once we do that, we will be on our way to achieve and sustain HIV epidemic in our target population. We would identify, provide access to, and retain our children and adolescents living with HIV and people living with HIV, retain them in care and treatment programs. We would also have a good outcome of improved socioeconomic status of our adolescent girls and young women, and improved professional development pathways for community-based cadre. So if we can achieve all these by institutionalizing the capacity development of our community cadre, we would really have gone quite a milestone. Next slide, please. This is what we just wanted to share, to say, as we are walking through this satellite session, let's think about these very important roles that our community cadre are playing as we deliver HIV services for OVC and in DREAMS. Thank you so much for listening. I really want to now hand you over to Stephanie, who is going to facilitate a discussion on some of the case studies that we have. Thank you. Over to you, Steph.
Thank you so much, Joyce. I am pleased to be able to introduce the presenters for our case studies, where we are going to share some of the experiences from across the ACHIEVE program, As Jen mentioned, we work in 8 countries. We have case studies that we're going to share with you from 3 of our countries, as well as our keynote presentation from Saj Samafara. So without further ado, I'm going to hand this over to Francis Nuagaba. He is the OVC and DREAMS advisor for the Achieve Rwanda program, and he's going to talk about coaching, mentoring, and supportive supervision for community volunteers. After his presentation, we will take a couple of minutes, probably 2 to 3 minutes for just one question before we move on to the next. If you do have a question, please put it into the Q&A option in the Zoom platform, as I will be moderating that throughout his presentation. So Francis, I'm handing it over to you.
Hello, everyone. Can you see me? Okay.
Yes, we can. Thanks. Take it away.
Okay, thank you. Thank you for that introduction. I will be sharing with you the capacity development for community cadres with a focus on coaching, mentoring, and supportive supervision that Achieve Rwanda has provided to the community cadres that we have worked with. Next. I would like first to share with you just a brief background about the Achieve Rwanda. Achieve Rwanda has implemented OVC and DREAMS for the past 2 years, and in the first phase, I would say, Achieve Rwanda supported the implementation of OVC and DREAMS that reaches about 67,219 beneficiaries, and this was done through partnership with Young Women Christian Association, as well as Duhamik Adri. These are 2 local implementing partners, but in support also with the Rwanda network of persons living with HIV. And in the next phase that started in October this year, so Achieve Rwanda shifted from direct service delivery to technical assistance as well as capacity building to the 5 local implementing partners. In the first phase, it was 2 implementing partners, but now it's 5 implementing partners. And these include African Evangelistic Enterprise, commonly known as AEE Rwanda, Caritas Rwanda, Duhamik Adri, FXB Rwanda, as well as YWCA. Next. How has been the Achieve's approach towards engaging and working with the community cadres? Just a brief background is that the community cadres that Achieve has worked with are unpaid volunteers that has been supporting the implementation of OVC and DREAMS interventions at grassroots level or at community level, with a range of activities that including enrollment or identification into the program, coaching, mentorship, as well as home visits and accompaniment to receive additional services beyond Achieve. From this graph, I would like to share with you the roles and responsibilities for Achieve DREAMS Rwanda, OVC and DREAMS Rwanda service delivery, where we have worked with, we are starting with the Achieve staff at central level, I can say. The Achieve staff here in Rwanda have been delivering trainings to IP staff. I mean the 2 IP staff, and these 2 IP staff also cascade the required training and skills to the community volunteers or cadres. They also provide on-site coaching as well as facilitation. This could be done on quarterly, monthly, or annual meetings. And from local IP staff being trained and empowered, they also go down to volunteers or cadres, and they are provided with these skills. And once the cadres receive these skills, they engage with the beneficiaries, be it adolescent girls and young women, as well as orphans and vulnerable children, as well as their parents or caregivers. In addition to that, volunteers make sure that they attend regular meetings to learn from each other to share successes, as well as what works from one region that one sector that another sector can learn from. So another point is the beneficiary as the direct recipients of the OVC and DREAMS package of services. Next. There is an interconnected structure of community cadres that Achieve Rwanda has worked with that I would like to share with you. Firstly, it starts with the implementing partner field officers, and these serve as overall coordinators, and they are based at district at central level, as well as at district level, where each implementing partner has field staff or field officers that closely support the district or districts of implementation, supporting the community cadres. The community cadres are grouped into those that supported OVC interventions, as well as those that supported with the DREAMS interventions. Let me start with the volunteers that have been supporting the OVC interventions. At the heart of the implementation is the case management volunteers, where Achieve has worked with about 981 case management volunteers, and these have been providing OVC case management approach, including home visits, like I mentioned at the start, ensuring there is adherence and retention to ART. There has also been the case management volunteer coordinators. So Achieve has worked with 127, and these have been supporting with data management, data cleaning, as well as ensuring there is reporting on program indicators and Achieve program indicators. Achieve has also worked with the farmer field schools that have supported OVC interventions, and it has worked with 110 volunteers, and these have been pivotal in supporting and building skills to around agriculture, as well as entrepreneurship for the OVC beneficiaries. We have also worked with saving group volunteers, these about 162, of which they have been supporting in ensuring the income generating activities are run and managed well, especially for OVC beneficiaries. Achieve has also worked with START, awareness, support, and action. That's SASA community activists. So these have been supporting the DREAMS implementation, and these agents of change that are based in community. So beyond safe space and beyond engaging parents, we make sure that the community is engaged. So these community, the SASA community activists go beyond the safe space and engage community at large. Through partnership with the Rwanda Network of Persons Living with HIV, the LLP Police, Chief has worked with 34 site navigators, and these are linkage facilitators that have been supporting and facilitating the linkage to receive additional services at their facilities, including ART retention, access to family planning, and other clinical services received at health facilities. Achieve has also worked with 193 DREAMS mentors that are key in delivering and supporting the implementation of DREAMS services. So these mentors are based in cells. So cells are small structures, in the government of Rwanda, where cell can be run by about 2 to 3 or 4 mentors, and these mentors are aged between 18 to 35 that support the implementation of DREAMS interventions, and they bring together the adolescent girls and young women at safe spaces. So safe spaces are community-based platforms where girls meet, discuss about their issues, learn about SRHR and other HIV prevention interventions. Achieve has also worked with the DREAMS ambassadors. In the past 2 years, we have worked with 2 DREAMS ambassadors that have been graduates from the DREAMS program. So the DREAMS ambassadors are previous beneficiaries that were enrolled and supported by the DREAMS program. so they are advocates or voices of the girls. To shed more light, going back to the dreams of mentors, on average, in Rwanda, a mentor could support or closely mentor about 80 to 90 adolescent girls and young women, while the CMV could closely support 7 to 10 households. A household has an average of about 5 to 6 persons here in Rwanda. Next. Yes, Achieve has ensured that there is capacity strengthening for the dreams for the community cadres, and this has been done through coaching, where community cadres have been provided with short-term and even structured coaching, where they receive different skills that help them implement the OVC and DREAMS interventions. They have also been trainings and skills development, where Achieve conducts training of trainers and ensure that the training of trainers offered to field officers or field staff has been cascaded to the volunteers. And these volunteers make sure that they train or educate OVC and DREAMS beneficiaries, and according to the design as well as fidelity of the curriculum. There also has been mentorship, where field officers, where IP field officers have been mentor community cadres on different interventions, but especially on how to become role models of OVC and AGY as beneficiaries, as well as making sure that they deal with this diverse group of people. So Achieve, as well as the IP staff, make sure that the volunteers have been mentored on how to deal with the changing and the diverse behaviors of the youth. Most of the population or the beneficiaries is youth. Through mentorship, volunteers have been empowered to the extent that they also help beneficiaries share their experience as well as testimonies. Next. Yes, Achieve has provided a number of trainings to the community cadres to ensure that they deliver the package of services to OVC and DREAMS. In OVC, Achieve has made sure that community case management volunteers have been provided coaching or training or managing on case management approach. The approach that is used by CMVs to visit and support OVC beneficiaries through accompaniment, through home visit, and that. Achieve has ensured that case management volunteers as well as teacher mentors, these are government structures that Achieve works with, have been also trained on sexual and reproductive health. Through Worth model for savings and lending groups, have been trained, volunteers have been trained on this model for OVC interventions as one of the OVC interventions. Case management volunteers as well as site navigators in partnership with the Rwanda Network of Persons Living with HIV. They have been trained on viral load monitoring and ART retention. Achieve has ensured that case management volunteer coordinators have been also trained on data management through electronic OVC electronic case management, a system that manages OVC data. Achieve has also provided training to case management volunteers on referral and linkage process. Achieve has also provided first-line support for survivors of gender-based violence training to case management volunteers. Farmerfield school volunteers have also been trained on Farmerfield school model that involves different agricultural and entrepreneurial skills. In DREAMS setting, the trainings have been offered mainly to mentors as well as DREAMS ambassadors. So starting with the sexual and reproductive rights, this has been curriculum that is provided to DREAMS beneficiaries and mentors as key implementers have been trained on this module. The DREAMS the DREAMS ambassadors as well as the mentors have also been trained on life skills, life skills education that also targets adolescent girls and young women enrolled in DREAMS. Chief has provided training on SASA approach, the start awareness of action approach for gender norms change, for negative gender norms change. Chief has also provided training on PrEP implementation at community level to mentors as well as DREAMS ambassadors. The BRAC awareness, the BRAC empowerment and livelihoods for adolescents, that's ELA model, is one of the models also provided to DREAMS beneficiaries, where mentors and DREAMS ambassadors are trained in this model to train beneficiaries. Mentors as well as DREAMS ambassadors have also been trained on gender norms module. This is a module that complements the SASA approach, because the SASA approach targets community beyond a safe space and beyond parents. So the gender norms now targets AGYW at safe space as well as their parents or caregivers. Mentors have also been trained on data management systems, especially on Rwanda DREAMS tracking system, a system that manages the DREAMS data, as well as reporting. Mentors and DREAMS ambassadors have also been trained on referral and linkage process, same as in OVC. Mentors have also been trained on how to provide first-line support for survivors of gender-based violence. Next. How do we sustain this capacity? So one approach is through government of Rwanda structures. So to sustain this impact, Chief has made sure that it engages different government structures to institutionalize and provide capacity. And through national level structures, including the Ministry of Gender and Family Promotion, as well as the Rwanda Biomedical Center, there has been joint supervision to make sure that programs and approaches are being evaluated and providing the needed impact. There has been formalized engagement with community-based structures, as well as there have been support to expand program impact through awareness campaigns, where Chief engages with the government structure at central level to support in different campaigns that are run by the government. At district level, there has been collaboration with IZU, that's Isutizu Mutiango, trying to mean friends of the family. So these are community-based structures that support the delivery of both OVC and DREAMS interventions. Local authorities have been also engaged to ensure that there is program monitoring and coordination, where we meet on quarterly basis to design the activities for the next quarter. Through collaboration and partnership with Isange one-stop centers, survivors of violence have been supported jointly. Chief has also worked with other education institutions, especially schools, where we train teacher mentors on provision of sexual and reproductive health through schools, now targeting both enrolled and non-enrolled beneficiaries, but that are attending schools. Through schools again, Chief has worked with coaching boys in 2 men, volunteers or coaches. These are teachers that coach OVC youth through games and through football games, where before the game or before the match and after the match, they are provided with messaging around gender-based violence prevention, where they are reminded to be the agents of change, that the boys that do not violate their girls, their sisters. Next. A few results that I thought I'd share with you is that through coaching, mentorship, and training these community cadres, there has been increased community cadre capacity, as well as engagement and retention. because they are trained, they are empowered, they are accompanied by field staff as well as their chief staff. So there is that increased retention. There has been improved individual performance because these community cadres have been monitored, have been coached, as well as engaged in joint supervision. And where there is any slight weakness, they've been guided by the field staff as well as chief staff. And this is a great achievement that we can share. There is also confidence and interpersonal skills that has been improved among community cadres as well as beneficiaries. There is also increased trust between the civil society organizations, facilities, and community cadres in HIV response through this network of community cadres that the Chief has built here in Rwanda. Working with community cadres is also an opportunity to guide them in their career. Most of them have been mentored and their skills have been improved or advanced. And there is a notable confidence that they justify that they achieved, they received from Achieve. Next. Yeah, that is a summary, but I welcome any comments, inputs, questions. Thank you.
Thank you so much, Francis. In the interest of time, I see just one question in the Q&A, and actually it's such a big and important question that I'm going to save it for the peer learning discussion. The question is to hear about experiences on payment-based competition between various NGOs over community-based workers. I think this will be a good one for us to address when Manji takes over the peer learning. So I'm going to put that one on hold and move us on to Desiree Luis, who is going to be giving us a presentation on how we reach marginalized communities through volunteers in our Achieve Dominican Republic program. Desiree, you want to take it away?
Thank you, Stephanie. Good morning, good afternoon, good evening, everyone. Thank you for giving us the opportunity to share our experience working with marginalized population through community volunteers in Dominican Republic. We are implementing the Achieve program in country with a unique approach, since the prioritized population are migrants and descendants from Haiti who live in our country. Haiti is a very poor country with which we share the border. Many people come from Haiti and stay illegally in Dominican Republic looking for better life opportunities. Haitians represent the main migrant population in country. As part of the Achieve program, we have two objectives. One of them is improve the HIV case finding and treatment outcomes through community HIV care and support and community clinic linkages. In addition to that, we support the improvement of the access of priority population and their families to complementary community level services. And the approach is based on a case management methodology that is implementing through a community network of 183 community workers, including community volunteers that do the case management in the community level, the household level, and the site volunteers that support the site level interventions, including the one handoff. From the beginning of the project to date, we have reached, as part of the OVC, more than 13,000 of people, including positive beneficiaries and their families, children, and caregivers. We have achieved that 95% of these people know their HIV status. The program is implementing in 5 provinces and the national district. Next, please. The priority population, as I was mentioning before, of our program are migrants and descendants from Haiti that are living in Dominican Republic, that are HIV, and are on treatment in facilities supported by PEPFAR and their families. These populations represent the group with higher prevalence of HIV in the country, between 2.5 and 5%, depending on the geographic area, in comparison with the national prevalence for the general population that is less than 1%. 40% of the priority population are aware of their HIV status, and from this group, only 28% are on ART. There are some risk factors for this population, such as extreme poverty, lack of legal documentation, and irregular immigration status that generate permanent risk of deportation. Limited access to social protection programs because of the lack of documentation, lower education level, language barrier because they speak Creole, that is the dialect that Haiti speaks instead of the Spanish, that is our official language in Dominican Republic. They don't have access to formal employment. They depend of informal source of incomes. And there are many discrimination with this population in Dominican Republic because they are migrants, because they are HIV, in addition to that, for the extreme poverty that they have. In addition to these risk factors and characteristics of this population, there are many myths, beliefs, and prejudice related to HIV and other items that affect the motivation to access to health services and accept the referral for services. Next. This is Judith Nair. She's one of our community volunteers. And she's supporting 19 families. As part of our model, each community volunteer has around 20 families that they support. In the case of Judith, she considers that the biggest challenges faced by achieved families is the lack of legal documentation and the irregular immigration status, because they are in permanent risk of documentation, of deportation. The beneficiaries can't get out easily and are afraid. As you can imagine, the people don't want to go to the facility, the people don't want to go to any provider to receive services that they need because they are afraid of the deportation. And the immigration department does the deportations in those places where they know that the high chance people used to go. In addition to this, some families are not very receptive and resist receiving services due to the myths, belief, and cultural issues that they have. And for that reason, it's important to identify those myths, those cultural barriers in order to increase the acceptance to the services and the referral. According to Judith's experience, the level of familiarity that she gets with the beneficiaries is very much appreciated, giving them confidence to the family as part of the strategic support and generating empathy, and also speaking in Creole, that is the language that they speak, in order to facilitate the bond with the family. Next, please. This is our case management model. As I was mentioning, the focus of Achieve program is the migrants and descendants from Haiti. For that reason, the entry points to the program are the positive beneficiaries, migrants or descendants, HIV positive, that are receiving treatment in facilities support by PEPFAR. We have a very close and strong coordination with the clinical partners who identify those in these clients that have children in their households and refer to Achieve for enrollment. We have site volunteers in the site level that support a one handoff in order to do the enrollment and assign the family to the community volunteers that we have in the community to do the case management process. As part of the strategy of the program, 95% of our community volunteers are migrants and descendants and speak Creole. That strategy facilitates the approach to this population because we have in the ground people that know their culture, that speak their language, and it's easier to create that relation, that confidence. The services that we provide in the program depends on the direct provision from the community volunteers. In addition to that, the referrals that we do to the different providers that we have in community level for the different services. Next, please. There are different sociocultural factors and contextual challenges that we have to consider in order to address this population. In terms of the contextual challenges, as I mentioned before, we have the cultural aspect, the myth, the belief that affect the acceptance to the services, the language barrier, and this population don't feel comfortable to talk about HIV and some sensible items. In order to address that, we have 95% of the community volunteers are migrants and descendants. And in addition to that, we prepare general guidelines to address those cultural barriers in order to define the specific approach that the community volunteers have to use to address the challenges related to acceptance for specific services. The case management materials, some of them, and the tools are in Creole, considering that our community volunteers are from Haiti too, and they used to provide accompanying to the services to the priority population when they have a referral. We made a survey with volunteers in order to learn more about those questions, topics that are uncomfortable for the families to talk about with, and for them to, in order to identify the specific approach required. All of these interventions are done under the guidance and with the advices of our priority population advisor that is part of our team. He's migrant and has a lot of experience working with the community program in order to guide the process that is more effective with this population. As part of the support to the children, we have community interventions to support the children in the academical process in Spanish, because the language barrier is a challenge for the children too. Next. As part of the other contextual challenges related with the case management and the social determinants in specific, as a result of the lack of documentation, they have limited access to the school after 6th grade, and they don't have access to social protection program because the ID is required for that. In addition to that, they cannot have access to employment. And because of the deportation, they are afraid to go to the facility. We have been developing vocational trainings to the beneficiaries. In addition to that, we provide the materials that they need to implement the trade in order to generate incomes and provide support to place the products and articles in places for sale. The documentation support is provided for those that are eligible according with Dominican Republic, and we provide the support to deliver of ARV in community and households level. And the engagement of private sector to do donations from food, material for the school, hygiene supplies has been done as part of the direct services of the program. Next. As part of the estimate discrimination, as is very common in HIV beneficiaries, they don't want to disclose their HIV status to the family. And sometimes they reject the home visits because they don't want that the families know, they don't want that the neighbor knows. In order to address that, we have a strong coordination with the facilities, with the counseling services, with the psychosocial services, in order to support the beneficiaries to go through that process. And we adapt the home visits according with their convenience in terms of days and schedule. And sometimes we do the meeting with the family in community places instead of home visits. Next. As part of the Judith Nair story, our community network, she emphasized that the creation of the confidence and the empathy with the family is the key to provide good support to them and get more receptive for the family to accept the services, to accept the referral for services. She has around 2 years working in the program, and as you did, we have other community volunteers that have a strong experience with the families, creating that empathy, considering the cultural connection that they have and the language that they speak that facilitate the bond with the family. And the type of relation that has been created between the community volunteers, as you did in our community network, has been the key from to get the acceptance of the family to be in the program and receive the services that we provide to them. Next. Well, thank you very much for this opportunity. we will be open to respond any question that you have. Thank you.
Thank you so much, Desiree. We have time for one question for you that has come up in the chat. The question is, how have you managed to assist immigrants with a permanent risk of deportation? I think you've touched on a few things, but if there's anything else you'd like to add, Desiree, please go ahead.
Well, that's the big challenge that we have every day, because we have to implement the case management process, the support to the families. And today you go to the household and the next day they are not there anymore because they were deported to Haiti. And sometimes when they are on the street doing the informal economic activity that they do, the caregivers are deported and the children stay alone in Dominican Republic. This is a very big challenge that we try to go around looking different strategies to maintain the services to the family, identify places that are more safe for them to go to receive the services in the church, in the sport area, in park, in the community, sometimes in the households when it's possible, when they accept. And we try to provide most of the services that we have in the portfolio services in the community, instead to reduce the participant to the facilities, because the immigration department do the deportation in different places, and one of them is the facility. Identification of providers close to the communities that they are living is a strategy in order to avoid that they have to move to long distance, because when they do that, they have more risk that the deportation department deported to them. It's a big challenge we have in the worst moment in the political situation between Dominican Republic and Haiti. United Nations asked to Dominican Republic stop deportation because of the risk that means for the Haitian people, considering the safe situation that they have in country. And the Dominican government said, it's not your business, we will continue with the deportation. It's an open challenge that we have to address. We have to survive to that and identify creative and innovative approaches to continue the support to these families.
Thank you so much, Desiree. I appreciate that response, and for all of your work with an incredibly hard to reach population, an incredibly vulnerable population in the Dominican Republic. Thank you. Just one final question for you, Desiree, is what is the ratio of community volunteers to households in your program?
Sorry, Stephanie, what is what?
What is the ratio of community volunteers to households? So how many households does each community volunteer support?
Okay, each community volunteer has around 20 households that they provide the support. We have some of them that have 18, some of them that 20, depending on the size of the target that the implementing partner have in the geographic area of the family, but around 20 households per community volunteer.
Great, thank you so much.
You're welcome.
Thank you, Desiree. I am going to move us on to Flora Nyagawa. She is our Technical Director for System Strengthening for the Achieve Tanzania program. And Flora is going to tell us a little bit about the unique approach that we use in Tanzania to professionalize community cadres through government structures. Flora?
Thank you, Stephanie. Good evening, good morning, colleagues. Good afternoon. I will take you through our experience in working with the Achieve for over 2 years now. And mainly I'm going to focus on professionalizing community cadres through the government structures. Next. Yeah, so Achieve goal in Tanzania is to improve access to HIV inclusive services, to improve the health and well-being of orphans and vulnerable children. And basically we are working along 3 strategic objectives. And strategic objective number 1 is focusing on the system of strengthening. And the second objective is focusing on the capacity building to the local partners or local organization. And the third one is focusing on the service delivery to orphans and vulnerable children, including the youth in HIV burdened communities. So each strategic objective have its own intermediate results. I'll not take you into one by one, but you can go quickly over it. But generally, what to take is for the one having more focus on system strengthening, the second one is capacity development, and the third one is the service delivery. On the right, you can see we have the map or where that's the Tanzanian map, and the blue color is where Achieve is operating. Next. So our background related to the community health volunteer in Tanzania has a long way history. You can see way back since 1967, our first president took initiative to make sure that the community health services are done within the communities. But going back to the 1978, where we had the Alma-Ata Declaration, we also supported that. And in 2014, our first national community-based health policy guideline was formulated, and it went into development of the implementation design. And over the last 2 years, in 2020, we came up with a new contextual and focusing way, whereby the new edition of the policy for the community-based services was also formulated and followed by the guideline. So really to say, there have been a wide range of community-based health programs and initiatives which have been carried out through the country, addressing different critical issues such as maternal, child, and neonatal health, HIV and AIDS, nutritional malaria, tuberculosis, adolescent sexual, and many more. So all these, they have emanated to make sure that the government is taking lead in making sure that we have a well-coordinated interventions, but also covering the human resource gap which we have to ensure that community level health interventions are well coordinated in terms of deployment, training modalities, supervision, motivation, and the incentives. Next. So quickly, I'll just mention some few challenges from the previous, before the 2020 guideline, of which we are working now, and the Achieve Real is contribution in operationalization of that guideline. So there have been different programs which are funded by USAID, and some of them which are non-USAID, and they're all working with the community workers, but with no standardized mechanism. And they have been having their own training modalities in terms of delivering different health and the social service package, but also absence of staff in villages, health facilities. We also had challenges in the coordination. Real this emanated making sure that the policy was formulated and the guideline, and now we are looking forward into the operationalize, and this where Achieve came in, and we are building on making sure that the operational guide is put into practice, and the CHW, they are taking lead in the community health activities. Next. So in 2020, the government of Tanzania, through the, this is our previous ministry name, it's the Ministry of Community Health and Community Development, Gender, Elderly, and Children. So developed the revised edition of the guideline. And mainly the main focus was really to put tools to guide the community in the process of identification, nomination, selection, to make sure that every CHW who is identified or nominated follow a clear path or standard to make sure that is working in the community, but also providing the comprehensive package of health and social services within the area where he or she is residing. But also it gives the standardized training package whereby community health workers and supervisor, they have to undergo training curricula or modules. And so far in the main guideline, we have about 7 modules or technical areas, of which I will give out the detail in the next slide. But also it lists down what kind of tools these CHW are supposed to be supported, how to identify the mechanism, clearing, define the roles and responsibilities, but also how are you going to give the performance-based incentive and so forth. Next. So what is mainly in the operational guideline of the 2020, as I pointed out early, it's clearly specified the procedure of identification and selection and motivation of these community health volunteers, but also to elaborate how services are provided and integrated. And it gives a description of the community system and governance structure. How are they going to be managed, supported, providing the community, technical support to them. And most importantly, to ensure that we are doing monitoring and evaluating the community health services provided. Next. So the operational of the CBHP policy through the guideline have been put into the context, and mainly in making sure that all the standardization and everything is done, but also since we are working within the community health approach, we have 7 modules. As you can see, the first module, basically, this is very basic. It gives all the details in terms of the community health activities. So, and the second one, give more on the reproductive, maternal, and newborn child and adolescent health. And the third one is non-communicable diseases, the fourth. And the fifth one is malnutrition. And module 6 is a fundamental social welfare practice for community health workers. And the last one is the basic curative services. So you can see I've highlighted the 2 modules in yellow, module 1 and module 6. This is real where Achieve is targeting. Basically, we are working within in delivering quality of health services to vulnerable children and their caregiver. So the module 1 give basic information to community health workers, which are working under the Achieve project. But also the last module, the 6th module, which is give more on the national integrated case management system or operational framework. So for module 1, these are focusing on CHW will undergo the 14 days we call mandatory training, and this give them the certification and the government recognize them. But the other thing more important is all CHW working in OVC program must complete module 6. So for example, one has undergone module 1, yes, within the community level can support these general community health activities, but for standardization and reporting and documentation, they really have to go and within the module 6. We have specific facilitators who are doing this. It's not everyone who will go and train them in each module, no. We have very specifically identified the technical staff within the government, and some of them coming from the implementing partners who are doing all those kind of training. Next. So what really has been key for Achieve role in professionalizing the community, Basically, as I mentioned earlier, we are working very closely with the government structures, and mainly we are working with the three ministries. We have the Ministry of Health, we have the Ministry of Community Development, Women and the special group, but also we have the President Office, General Regional Administration. So as you can see with the names, the Minister of Health oversees all the policy issues related to health. The Minister of Community Development is related to all issues related to gender, children, and special groups. And the President Office, this is our ministry which oversees implementation at the community at the lower level. So we have been targeting the two areas, as I said, the operationalization of the CBHP guideline. So we have been able to support the review, the translation, because some of the documents were developed in English. Now our main language is Swahili, the printing, but also training in mandatory module, but also operationalization of the National Integrated Case Management within the community. Yeah, next. These are some of the numbers which we have been able to achieve in working with the community health volunteers. As you recall from our objective 3, focusing on the service delivery. So they are connected within the 3 objectives. And the third objective whereby we see these numbers, we have been able to reach working with about 17,000 plus CCW, or we call now the CHW, but also reaching about 678,000 plus OVC and caregivers and family in various services. But also we have been able to support the government to transition. The about 726 now are very formalized within our project. That's where we are working with. Next. Yeah, from the numbers, you see what really we have been able to do. It has helped us with the improve the case identification and linking them to ART and the issues related to virus suppression. We can see they are able to do the HIV risky screening for orphans and vulnerable children, but also supporting accessing medical care. More important, also improve delivery of comprehensive case management services to children living with HIV, facilitating effective referral and linkage, the use of various tools developed by the government. Also, we have been supporting that. So all the process of the case management, they have been very key, these volunteers, to make sure that these orphans and vulnerable children access services within the standardized way, from the identification, screening, care plan development, but also in the process of graduation and case closure. Next. What are the key learning from the community volunteer cadres? We see there is a high demand, and community volunteers now are ready, and because they are embraced, they are recognized, but also the provision of mandatory training to CHW requires a lot of resources. As you can see, some of the training, especially Module 1, needs about 14 days, and that's in terms of finance, time, and everything. Provision of working tools for achieve, we have been able to support that, and that's really a kind of motivation, and these CHW appreciate and feel like they are recognized and they are supported. But also combined skill for Module 1 and 6 give more strength to the volunteers we are working with. Next. So what have we been able to see in some of the anticipation we are looking forward, but also the government is seeing? One is the high level recognition of CHV, meaning the volunteers, but the operationalization of the National Integrated Case Management and the CBHP itself is now going upward, and effective identification of orphans and vulnerable children have also been well continued. Timely identification and reporting of VAC and GBV cases, referral and linkage to various services. All these have been giving out a robust and the agile community health system through investing in the community health cadre. Next. Thank you so much. Asanteni sana.
Thank you so much, Flora. It looks like we've had a couple of questions come up in the chat that actually I think, Flora, you might answer, or they might also be open to Desiree or Francis, just quickly before we hand over to Saj. The first question, there's actually a couple on this topic. How do we keep volunteers motivated in our programs to the extent that they may be unpaid or only receiving stipends? Flora, Francis, or Desiree, does one of you want to chime in and respond?
Yeah, I'll respond, and maybe if we have time, my colleagues will add up. Basically, keeping the volunteers, of course, we have some stipends. Really, it's not a payment, rather making them to work on their daily, moving from one point to another. But also we have been able to provide ongoing capacity building in terms of orientation, but also we are supporting having them meeting on a monthly basis, whereby they have exchange of ideas, and also they get technical support from the government personnel. So real for Achieve staff, we are not everywhere and we are not there. It's the government who is taking lead to ensure that they are providing support, providing guidance, giving them encouragement. And in some of the villages, you find they're excused from other core community work, and they are given opportunities to give out topics, for example, in the health awareness campaign. And real people, they feel recognized and they are supported and feel motivated. Thank you. Back to you, Stephanie.
Oh, thank you. I was on mute. Desiree, do you want to respond as well before we go to the next question?
Yes, thank you. In the case of Dominican Republic, we have built this relation with the community volunteers in the framework, the volunteer law. That required to, in addition to provide to them all the materials that they need to do their community work, we have an insurance to cover any accidents, any emergency that they have during the community work. In addition to that, we have a contingency fund with the same purpose in order to cover those needs in emergency that could happen that the insurance don't cover. We provide to them all the materials that they need, including non-traditional materials as umbrella, I don't know how to say in English, but lighter, because sometimes they have to go to the households during the night, and we have many blackouts in Dominican Republic. And periodically we do recognition, and we provide to them certificate considering the performance and the productivity.
Thank you. Francis, you're on mute.
Oh, sorry.
There you go.
Okay. Yeah, in addition to what my colleagues have, I want to mention that most of the volunteers we have here in Rwanda, at the time of recruitment, we highlight a key point that is around volunteerism. They have to be the kind of individuals that love volunteerism, and this allows them to stay on board. In addition, they don't serve beyond their cells or their catchment area. So that also allows them like not overwhelmed by work, as well as the ratio, the beneficiaries they serve or they closely support. So they support a closely relative number of households as well as beneficiaries. So this also allows them to not get work overload, which at some point allows motivates them to stay on board. Others are also provided with some stipend as well as transport facilitation. Over. Thank you.
Thank you so much, Francis. There's a couple of other questions that I think we're going to answer in the peer learning discussion facilitated by Manji, but one just quick final one for you, Flora. What is the retention rate of volunteers in the Tanzania program?
So far, real, I would say it's above 90. Real, it's they don't move so far. And this one, I will also connect with the other one. The volunteers we are working with belongs to the government. For the project real, we are just building on and supporting because they are recognized by respective villages or the local community. So for us, when we go to the community, we are working with the volunteers who have been identified by the community. And if they have not been able to be identified, we support the process. So they're identified by the government and they belong to the government. And this real, for us, project when it ends, there's no way they will end there. They will continue. Because some of the volunteers we are working with, they have been working maybe 3 past projects. There was another one project, there was another one. So you find really some of the volunteers have about 10 years plus, 15 years plus, and real, yeah, that's where we are happy on that. And we see this is a good move where the government have taken. Because real, the government, we don't own volunteers, rather we are supporting them. Thank you. Back to you, Stephanie.
Thank you so much, Flora. That's those are great results to hear that there's volunteers that have been sticking with it for up to 10 years. Thank you. Okay, we're going to move on to our next presentation. Note that the questions that we have not yet touched in the chat, we will come back to in the peer learning discussion. But I do want to hand it over in the interest of time to Saj Samafara. She is the Executive Secretary for RRP+, which is the Rwanda Network of People Living with HIV and AIDS. And I'm really excited to have her talk about how they have institutionalized the role of the site navigators and people living with HIV within the health system in Rwanda to support other people living with HIV. So Saj, take it away.
Yes, thank you very much, Stephanie. And thank you very much for my participation in this session on institutionalizing a community partnership with health facilities. I will be sharing our experience on the role of the RRP Plus site navigators in Rwanda. Next. Yeah, we are a national umbrella or civil society organization that supports people living with HIV. The organization was founded by people living with HIV and family affected by HIV. In Rwanda, we support mainly people living with HIV in their diversity, including children, adolescents, key population, priority population, and adults. And also we have a special consideration for pregnant women in PMTCT program. So countrywide, we have associations as implementing model. We have associations at a sector level. This is a grassroots level. We have cooperatives that generate income activities, and we are an umbrella of 16 NGOs, local NGOs member that support the health facilities within countrywide. And then at the national level, we have the executive secretariat that supports in the implementation of all programs and projects. Next. I would like to share with you the pyramid of delivery is structured in Rwanda. We have, first of all, the community. The community health workers in Rwanda is an entity that has a big role in the community awareness, community screening of different diseases such as malaria, HIV, tuberculosis, and other diseases. So at the community level, we have those community health workers where also our community volunteers are working with those community health workers. So we have at village level, we have those community volunteers, and the community volunteerism is most the model that is promoted in Rwanda. So at cell level, we have health posts where community health workers or community volunteers refer when is needed. They refer patients at the health post, and health posts refer at health centers. Here, I would like to mention that our community volunteers, as people living with HIV, they work at village level to refer patients at health centers, because the HIV services is delivered at health center level. So at the health center level, I will mention that is at the 5 kilometers walking, where patients can walk 5 kilometers. So it's not far. And the HIV services is delivered at each health facility, health center, where we have at least one center at sector level. Then a hospital, or where in each district we have at least one district hospital, which also refer to the provincial hospitals, and then provincial hospitals refer to the they refer to the pyramid of health in Rwanda. Next, please. For HIV services, we have involvement of all partners in HIV response, where still we have a main goal, an ultimate goal of HIV program is to end HIV by 2030, where we have we need to ensure that we can achieve 95 goal, where 95% of people who are HIV positive should know their HIV status, and among them 95% should be in treatment, and 95% of those in treatment should be suppressing their viral load. So this goal is supported by the HIV goal within SDGs, where we have the third SDGs, which says health for all, and the HIV is including in this international target. At national level, we have the National Strategy for Transformation, one, where HIV is integrated into the national strategy. At the ministerial level, we have the health strategic plan, where HIV is a priority in the ministry strategic plan. And we have the Rwanda Biomedical Center, which is in charge of disease management and prevention, where we have the national HIV strategic plan for HIV, where we have all strategies to mitigate the impact of HIV and prevention, as well as care and treatment. So here we have involvement of different partners, including we have development partners, UNHCRs, we have national and international NGOs, we have civil society organization and private sector. So the community is has important role in community still mobilization, referral, and also at the community level, it's where we have our peer educators. Peer educators are those who support their peers. They are people living with HIV, volunteers, and they support their peers at the community. Next. As a path to success for the Rwanda Network of People Living with HIV, this organization was founded in 2003, where you remember all that at that time there was a high level of stigma and discrimination. Being HIV positive was meaning death, no hope, but later, five years later, we came up with the initiative of peer education at the community, where we started to work with volunteers, those who are openly positive. We started to work with them in 5 health facilities in the country, and we continue to advocate for the scale up of this peer education program, because we found that among those people living with HIV who are supported by peer educators, they are improving their life in terms of social support, economic support, whereby in 2010, we started also to intervene in income generating activities by creating associations and cooperative of vulnerable HIV. Later in peer education and 182 health facilities in country. This was by the support of CDC under PEPFAR support. And later in 2016, the Ministry of Health launched the Treat All, where we started now to support peer education, where someone who is tested positive starts immediately treatment. And now we are supporting 74% of people in treatment in different category of groups. And we have peer educators countrywide in all health facilities, 533 facilities. So this is a big achievement in terms of engagement of the community, engagement of beneficiaries, because they work at voluntary based, and they can improve the life of those who are in treatment. Next, please. Yeah, this is the image of our peer educators. They are well equipped to institutionalize the community support. The government has been very supportive on this initiative, because we receive support from the government on the training of those peer educators. they are well equipped. You can see that they have raincoats, they have badge, they have umbrellas, they have torches to be able to work even in later hours. They also have everything to support them in what they are doing. So LRP Please really is the Rwanda network of people living with HIV, but in French is réseau. Someone asked the question. As I said, in all health facilities, owners, which are global people living with HIV, in 33% of people living with HIV are supported by PEPFAR, and 67% are supported by the Global Fund. And all this support because Rwanda works with the result-based funding. All partners engaged with the Ministry of Finance to as the governments distribute our support come directly, the funding that we received from PEPFAR and Global Fund. Next, please. Next, please. Yeah, this is the data of peer educators. We have, as you can see, we have over 4,000 peer educators, and the ratio is that one peer educator supports between beneficiaries at the village level. And we support different categories of people, as I said, adults, we support key population, we support adolescents and youth. And as I said, we support 74%. Next, please. Yeah. Here is the number, is data of the people we serve. At Global Fund supported sites, we support over 75,000 of people in treatment, and in PEPFAR supported sites, we support over 81,000 people in treatment, including children, as I said, adolescents, adults, and key population. Next. Yeah, on OVC program, we have a very strong OVC program where we support, we coordinate the support of over 34,000 OVC countrywide. And those OVC, I'm very happy and very proud of Achieve program, because it supports almost the half of those OVC beneficiaries. So they are mainly supported through school fees. They are supported in school materials, and also they are supported in technical trainings, which support also their families, because we only don't support those OVC, but we have a family-based care. In the family-based care, where we also have these cooperatives, because parents are engaged in cooperative where they generate income activities, and children benefit from those income generating activities from their parents. And we have developed saving groups among communities, among village neighbors. They also work on savings programs. Next. Next, please. Why do we support and also advocate for the empowerment of vulnerable children? I would like to share with you this success story. This is a girl who became mother at her teenage, and the risk factors of this situation, this life, was lack of information about sexual reproductive health, family poverty, and also lack of knowledge on how the girl can be empowered. That's why we really support and encourage girls to be in DREAMS program and also OVC program. So being a teen mother, this teen mother could not even receive any support from anywhere. She was abandoned from her family, from friends, from the community, high level stigma in the community, in the family, because she was in a family of pastor family. So you can imagine that in a family where we have religious, they cannot, the acceptability of this situation, it can be very tight. So by chance, these adolescents got an opportunity to serve in the community as an agent of change in her community, and she could be able to raise her baby girl. And later on today, we can be proud that this baby girl can be a young girl who is also advocating for empowerment of young girl in her community. She's a leader of young girl in her community. And this young lady who was also a teen mom is the one who is speaking with you, who is me, myself. So I really support the engagement and empowerment of vulnerable children, vulnerable girls, because they can achieve more. Today, what I am because I have received support from a program like DREAMS and also OVC in my past. Next, please. So within the OVC program, we have since 2020, RRP Police joined the Achieve Consortium to contribute to HIV epidemic control in Rwanda. This was possible with the engagement of 34 site navigators. These site navigators come from people living with HIV who are peer educators. They are existing peer educators who became site navigators in a RRP Police program, peer educators, to support Achieve and its local partners to strengthen community and clinical HIV testing services and promote adherence to treatment for beneficiaries in OVC and DREAMS activities. So the main responsibility of site navigators is to facilitating the enrollment of over 17,000 beneficiaries in the program. They empower and make linkage of case management volunteers to health facilities. They also enhance collaboration between health facility providers and OVC program volunteers to strengthen community level support of children and adolescents living with HIV. They also support on coordination for the meeting of CMVs at facility level, also to create a good environment to support the sustainability of referral system. So as achievement, those site navigators have supported to have over 17,000 beneficiaries who have been enrolled from the 33 health facilities and served by Achieve program through the facilitation of peer educators in the community. Those 34 site navigators have facilitated to strengthening the linkage and collaboration of health facilities and CMVs. So those CMVs who are case management volunteers and also site navigators support children and adolescents living with HIV and their caregivers with counseling and education to facilitate viral load suppression monitoring and also linkage to care and treatment. So we are very proud that 99.8% of beneficiaries of Achieve have suppressed their viral loads. This is the big achievement that we can be proud of for Achieve program in Rwanda. Next, please. So I was talking about the income generating activities in cooperative. Today, you can see that parents of those children are supported through cooperative. They can do different activities such as agricultures and many activities in the community to make sure that their families sustain and also adhere well in treatment. Next. To make sure that we have community feedback and also receive the issues that are surrounding the community, we have initiated a community call center where everyone can call freely to receive support on different topics, HIV prevention, care treatment, and also fighting stigma and discrimination among people living with HIV in families, the community, and also to make sure that people living with HIV and their families, children, are receiving a quality care services at health facilities. So we have this free line for the community where everyone knows about this community call center. They call freely and receive services. Next. As a result, and also we are proud to have been awarded by PEPFAR at global level to be the civil society organization that have been working with the government closely and initiate many community creative activities at the community to make sure that the community is healthy and also receive quality of services. So we are also recognizing the effort of the site navigators through peer educators, and is with this award belonging to all community health workers in Rwanda. Next. Thank you very much for listening to us, and any question we are happy to answer. Thank you.
Thank you so much, Saj, for sharing the work that you all are doing at RRP Plus, and also most importantly for your story and how you, as not only a person living with HIV, but also a community member, have been able to empower others. That impact I know is pretty profound in Rwanda. So thank you so much for that. Because our next session is all about questions and discussion, what I'm going to do is I'm going to hand it over next to Manji Rangshwat. Manji is our project director for the Achieve Rwanda program, and he is going to facilitate a discussion amongst all of our presenters and even amongst all of our participants, because we wanted to use this opportunity as a chance to hear from you so you can all learn from each other. So Manji, take it away.
All right, thank you very much, Stephanie, and hello everyone. For the peer learning discussions, I will be leading the session. We've prepared a couple of questions that are also related to some that we've seen in the chat box. And for this session, we will start with having the presenters respond to these questions and then allow all participants to also be able to share their own experiences. You can either use the Q&A or chat box to drop your question, or raise your hands and you'll be unmuted so you can be able to respond. So starting with the first question, I know a lot of partners have raised, reported a number of challenges in terms of high level of attrition for community volunteers. So what we want to find out is what strategies and approaches you've been able to use in your various projects to promote and enhance community volunteer retention. So maybe let's start with Francis.
Thank you. I think my video can't start. Is that okay if I go on without video?
Sure, please proceed.
Okay, thank you. Yeah, in Rwanda, through Achieve Rwanda, like I touched it a little during the presentation, to make sure that we retain the community volunteers that we have worked with, we have ensured that, first of all, we identify or recruit volunteers that are based in the catchment area that they will serve or that they will help implement either OVC or DREAMS program. And this allows the volunteers to navigate around that small catchment area, support the beneficiaries. Okay, let me put it on. Okay, thank you. Yeah, in addition, we have ensured that the ratio of beneficiaries to the volunteer is reasonable, in a way that, if you remember in my presentation, I highlighted that in Rwanda, like for the DREAMS program, about 80 to 85 beneficiaries can be supported by one mentor. And in OVC, about 7 to 10 households can be supported by one case management volunteer. And this ratio allows these volunteers to not have like work overload or to be overwhelmed by work, which makes their work easy, as well as, I can say, loving the environment, continuing to stay on board and continuing to support these beneficiaries. One more factor I can mention is that there is this close support from field officers as well as the Achieve team, in a way that the field officers, the IEP, the implementing partner field officers, closely visit the volunteers during service delivery. This somehow allows the volunteers like to feel they are supported, they are closely supported by the staff as well as the Achieve team, and this allows them like to continue supporting the program. When they encounter any challenges from beneficiaries, they have the field staff around that can easily help them figure it out. One more experience that I would share that has helped us also keep these volunteers on board is that they have been, we have recorded a number of volunteers that have become staff. Even Trace mentioned this. And this motivates the other volunteers like to stay on board. You never know, tomorrow might be my turn. I might also be field staff like my colleague has been. Thank you.
So Francis, before you go quickly, can you also touch on the issue of stipends? Your community volunteer, do you provide any kind of stipends to the volunteers? Do you face this kind of competition among other organizations in terms of how much they also get?
Yeah, thank you, Manji. For the stipends, yes, like some volunteers provided with stipend, especially the DREAMS mentors. And this stipend allows them, like with the transport, able to maybe go and support in areas that is, let's say, hard to reach, something like that. But there are other volunteers that do not get like this monthly stipend, but they stay on board as well. So regarding the competition, maybe the competitiveness of the stipends, one organization provides, the other organization provides. Yes, it's a challenge. We have also had that here in Rwanda, where some volunteers, some organizations provide quite, I can say, a high facilitation than the other. But the way we have handled this is that we ensure that our volunteers receive quite a high package of trainings and skills development that the other organizations say do not provide. We also try to explain the package of services provided. For the other organizations, they provide a quite different package of service, maybe that needs quite high number, quite high facilitation. For instance, an organization might be providing a facilitation fee because to the volunteer, because that volunteer will move maybe around the whole district, but ours are based in a cell, so it's very, very small catchment area. I don't know if I can answer.
All right, thank you very much, Francis. Choice, please, over to you. And then if you can also hear from Flora and Desiree.
Thank you so much, Manji. I also wanted to mention that non-monetary incentives also contribute a lot towards retention of community cadre. In communities where they are serving, if there are certain community meetings and a community leader stands up and gives public recognition of the work that is being done by our community cadre, it really goes a long, long way, and it really lifts up their self-esteem. And then us providing the necessary tools for the work. We had in the presentations provision of uniforms. It could be t-shirts, it could be hats, caps, umbrellas, but also giving them money for calls, where we have a communication line item in our budgets, giving them money for transport if they need to be supporting with transporting some of our beneficiaries from point A to point B. It really goes a long way when they feel they are being supported in the work that they do, and it contributes towards retention. Thank you.
Thank you, Choice. I can also see Serge raising her hands. Please go ahead.
Yeah, thank you very much. I would like just to add on what Francis said. First of all, I would like to add that in Rwanda, the voluntarism among the community is a leadership willing. So this voluntarism started by our leadership. So in Rwanda, the promotion of voluntarism is very huge, because even our leaders, they have a voluntary work that they do. So as promoting the voluntarism in Rwanda, everyone feel to give back to the country, to make effort in any voluntarism work in his community, just to give back to the country. Because even our leadership is also working hard to improve the country development. And also in terms of incentive, For example, for our site navigators who are also peer educators, they only receive transport and communication, which is less than $10 per month. So, and the big thing that is there is that their recognition in the community is something which contributes to their effort and also give them the courage to continue the work. Thank you.
Thank you very much. I think let's move to the second question because of our time. During the presentations, a lot has been shared around government involvement and participation throughout. Can you share examples of key institutionalized approaches used by government at different levels at your country program to incentivize and sustain the community cadre role in the OVC and DREAMS program? Permit me to start with Flora. Flora, can you respond to this?
Thank you, Manji. I'll not go very far from the other, some of the colleagues. For Tanzania, as I said before, really the government is taking lead on this. So from the identification, nomination, and everything, the government structures their part in the process. And this really has given us, in working in the areas where we are operating DREAMS activities and the general OVC comprehensive, we have active community health workers who are working voluntary. And this the government also keeping on taking lead, ensuring that they are provided technical assistance, whereby social welfare officers, health officers from the higher level, meaning from the local government authorities, they go to the communities and visiting these community cadres. So for example, what is really being done, they have these coordinations meeting within among the community volunteers on monthly basis, where they discuss challenges, success, and if there's any challenge here, the technical people from the government, they are able to provide a solution or provide clear guidance. But also the DREAMS programs whereby the DREAM girls, they are brought together and the government is overseeing all that. But also the other thing which have been real beyond the working within the DREAMS only, for community volunteers, they have been doing multiple tasks. For example, with the COVID-19 when came in, they have been playing a big role in creating community awareness in terms of prevention, but also now we have moved to the vaccination. They are really taking lead. So really looking at the perspective in providing community based in terms of focusing for OVC comprehensive and DREAMS generally, they have been able for the government to play a big role in making sure that they are monitoring and providing guidance to the project in general, but also to making sure that these community volunteers are operating within expected standards and the guidelines. Thank you.
Thank you very much. Desiree, you want to add something from your country program?
Yes, thank you, Manji. Yes, in addition to the volunteer law that I was mentioning before that the government has, they defined recently a new process for the volunteers that work in country. That is a national registration of volunteers. And they will have information about all the volunteers that we have in Dominican Republic, not only for the OVC program, for all social programs in Dominican Republic. And periodically, they do an award in order to recognize the role of those volunteers. The organizations present candidates according with the requirements, and that person is recognized for the work that they are doing. It's important to highlight that considering that we have site volunteers in the sites that we are working with, this quadrant, in addition to the chief's role, they support other tasks in the facility as part of the support to people living with HIV/AIDS. They do tasks inside of the facility. In addition to that, the facility recognizes the support that they provide in the adherence and retention to the beneficiaries, in addition with the role of our community volunteers. During COVID too, our community volunteers were doing ARP delivering community level, in the household level, you know. It means that the government has been recognizing the relevance of these figures. And with this volunteer law, we have the expectation that this figure get more recognition. The challenge that we have in the case of our volunteers is that most of them, 95 of them, are migrants or descendants, and many of them don't have ID. It means that although we have this big group of volunteers, not all of them will have the opportunity to be enrolled in that national registration that the government is visualizing, and maybe because of the lack of documentation, they are not going to be eligible in the case that the government decides to maintain those cadres in the facility after the SHIFT program are finalized. But anyway, it's a good step that the government took with this volunteer law, and they are creating many mechanisms to motivate, maintain the volunteer work in Dominican Republic, motivating the organizations to work in the framework of this law. And that is important for the program. We have been discussing in different moments, although we don't have a specific objective for that, with the National Services for Health, in order to talk about the possibility that the site volunteers and the community volunteers are included in the structure that the services have in the first level of attention to maintain those interventions after a SHIFT program finalized. In addition to the materials, training, insurance, and the contingency fund that we have for the volunteers, we do a monthly contribution, monetary monthly contribution to them to cover all the transportation costs, communications card, per diem, and you know, to motivate the work that they are doing. It's part of the requirement of the law, that monthly contribution and the finance support for all of the tasks that they have to develop.
Thank you very much, Desiree. Let's move to the third question. And for the third question, please, for participants, if you want to respond, feel free to either raise your hands or drop your responses in the chat box. Thanks to Wilfred, I can see a detailed explanation of your experience in the chat box. So for the third question, I know all the presenters mentioned the different kind of trainings that they provided for the community volunteers. And this is because their technical capacity is also key for quality service delivery and then sustainability. So can you share your experiences working with institutions of learning or government ministries of education to institutionalize the training and certification of community volunteers through either a certificate or diploma programs? Maybe let me start with Flora. Flora, can you hear us?
Yes, Manji.
Right.
Yeah, so for Tanzania and for Achieve, what really we have been supporting is a certification by training these volunteers in standardized training modules or training package. And we have not gone further to engage the specific institution, but rather this is done under the Ministry of Health in collaboration with the President Office, which is overseeing the local government authority. So as I pointed during my presentation, the facilitators or the trainers has been certified by the Ministry of Health. So even for the training, it's clearly one to be certified has to undergo a specified number of days in each particular module. So for example, module 1 is 14 days, module 6, which we are as Achieve really we are supporting that is 5 days. So all those, the facilitators has to monitor each CHV to making sure that has been able to attend all days, and definitely they will do registration on daily basis and monitor their participation within the classes. And once completed, they will be issued with the certification and supported them with the working tools, both in working years in terms of part of motivation. Thank you.
Thank you so much, Flora. And I think we have 2 hands raised. Let's take Abdullahi Abubakar. Please go ahead. Abdullahi, please unmute Abdullahi. All right, so while we wait for Abdullahi to be unmuted, Victor, please go ahead.
Okay. Hello, can you hear me now? Yeah, can you hear me?
Yes, we can hear you, Abdullahi. Go ahead.
All right, good afternoon from Nigeria here. My name is Abdullahi. I work for XA3 OVC project in Nigeria, basically Kanu, and we work with Achieve to provide support for the OVC. Areas. Yeah, from all the presenters to build on to improve on some of these areas you've highlighted. I just want to share a little of our experience when it comes to issue of strengthening the social work and the community case management workers, CADA. I know XA3 alongside Achieve here in Nigeria has for the internal training we have IV and other trainings. What we observed was the volunteers or the case management workers we have here. Most of them are into providing humanitarian services, social work services, but they lack the basic skills and certificate to carry out that. If you could remember, Manji, I know in Nigeria, the Nigerian Social Work Association are pushing for a bill that will support humanitarian services, that all those that are into humanitarian services must obtain a certificate, a minimum professional certificate that will back up their service provision. XA3, when we started in Kanu, we conducted a baseline assessment of the social work alongside with the government of Kanu, and we realized that 65% of those that are working in those areas lack the qualification, volunteer or the case management, I may call them skills, and come up with an auxiliary social work certificate. We advocated to the government.
Abdullahi, can you hear me? Can you hear?
Yeah, I can hear you very well.
Can you summarize so we can move to the next question?
Okay, so what we did was to institutionalize a curriculum for professionalizing our lower cadre workers, both at the government level and our community case management workers. One is to ensure that after the project, after USAID XA3
So it seems we've lost
the follow social workers and provide these services. Now, prove it. You can hear me? Hello?
Go ahead, we can hear you.
Okay. Despite working with the volunteers or the community social workers, what I was seeing was to ensure that at the end of the project, they have a certificate. We institutionalize and the auxiliary social worker with alongside the canons, and we're encouraging all our community workers to obtain. They've done their
All right, thank you very much, Abdullahi. Stephanie, please, the next slide, please.
The semester exams will be to
All right, so the final two questions we have for this session are, apart from coaching, mentoring, and targeted trainings for community cadres, have you explored options like setting up community cadre, community of practice, holding community cadre peer learning events, or convening community cadre networks as part of plans for sustainability? Maybe let me give Francis this opportunity to respond to this question. Within a minute, please, Francis.
Thank you, Manji. In Rwanda, let me start with the DREAMS ambassadors. For instance, the DREAMS ambassadors have a chance and a platform to meet. Like each district has a DREAMS ambassador, so they would meet, learn from each other, be it virtually or in person, share experiences, how they are supporting adolescent girls and young women enrolled in DREAMS. We also have quarterly peer learning events where volunteers meet, like volunteers from the whole district meet on quarterly basis to share experiences, what is working, what needs to be improved, and they hear from one another. Let me give you an example. Let's say one district has around 10 sectors, and that's around 90 mentors. So they meet on a quarterly basis and share these experiences. We also hold at the start of the year what I would call the co-creation meeting, where, for instance, this year, district engagement meetings, where volunteers were involved in these meetings, and they could share what needs to be improved, what can be incorporated in the next scope. So this is also part of the sustainability. Another idea that we think of championing is ensuring that volunteers move from one IP to another IP. Since Achieve will be providing technical assistance in this new scope, we will try to see how there is this outreach. Volunteers move from one implementing partner and go visit the other implementing partner. Thank you.
Thank you very much, Francis. So the final question, maybe let me just allow either Choice or Desiree to respond to this. What roles are your community cadres playing in the implementation of community-led monitoring of service delivery? Choice or Desiree?
Okay. I was waiting maybe for Desiree to start, but what we are doing with the community monitoring or community-led monitoring of services is where we want to give the opportunity for our beneficiaries or the target population that we are serving to be able to give feedback to the community cadre on how they are receiving their services. So in the pilot that we did as we were pilot testing the community-led monitoring tool, what we actually did was to come up with a variety of tools which would now be administered to the target population, and they could be giving the feedback on how services are provided, what else could they want to see, and how else would they want to see the service provision being improved. And when we take that feedback and we input it in our next set of implementation, actually the target population is very excited to see those changes, and it also encourages the community cadre to see that their services are being appreciated. And at the same time, you would also note that the community cadre will continue to want to know more feedback from the target population by giving them these on a regular basis. So institutionalizing getting feedback would become one of the key elements in Achieve programming. Desiree, you can also add.
I think our time is up. Permit me to hand over to Stephanie. Thanks to everyone for participating in this discussion. I can see some very useful learnings also shared in the chats. What we can do is to collate this feedback and then share via email with everyone at the end of the session. Thank you, and over to you, Stephanie.
Thanks, Manji. I'm actually going to give this to Jen to do a quick wrap up and thank everybody. Jen?
Hi, Stephanie, can you hear me?
Yep, go ahead.
Okay, so I think that we can all agree that the community volunteers are champions. They generously give their time and share advice with people in their own communities and link them with health services. Their knowledge and dedication will help to sustain the HIV response. You know, as part of system strengthening, we have ongoing efforts to advocate with ministries to budget for these important cadres. Notably, Francis shared that in Rwanda, training and mentoring is ongoing and in-depth. The team is consciously working to sustain these activities through joint supervision with line ministries and integration into community-based structures, especially schools. Volunteers are members of the community, and thus they are accepted more readily. Desiree shared that it's especially important in challenging situations like in the DR, with Haitian undocumented immigrants. Essentially, they can become children's only safety net. In Tanzania, Flora shared that it's been key to work with the line ministries on training and certifying CHWs. Policies and guidelines have been developed and agreed upon to this end. And to professionalize the volunteers, it was important to develop and standardize training packages and tools. In Tanzania, over 700 volunteers have become CHWs so far. You know, however, we do still have questions about resources, both time and finances, to allow for sustainability. We can see that DREAMS empowers adolescent girls and young women and makes future leaders who give back to the community. It was wonderful to hear about Sage's inspirational story from Rwanda. Finally, I think it's also important to note that these trusted community volunteers may be utilized to address emerging health threats. And in several achieved countries, they were helpful during the COVID response. I want to thank the presenters. I want to thank the participants. We had people from 16 different countries, ranging from DR all the way across Africa and through to Indonesia. And I want to thank Stephanie Calvez especially for convening us together for this satellite session. So thanks everybody for joining, and have a great rest of your day. Bye-bye.
Bye-bye.
Bye, thank you.
Thanks.
Thank you.